as now Dr. Deepika has explained how treatment is there, and she has also slightly touched on the part that once you have treated the patient, it is how the patient responds and how the patient is monitored, which will also determine the further course of how the patient is going to fare. And so now I will invite Dr. Jyoti Kotwal, Dr. Professor Jyoti Kotwal, ma'am, who is our professor and head of department uh, of hematology and molecular medicine. She is head of DRNB clinical hematology program at Sarvaganga Ram Hospital. Ma'am, as we are all familiar, she is the teacher par excellence, and to her credit, has immense experience. Ma'am is also FRCP and FAMS. She has a fellowship in hematology, and she is member National Apex Committee for Super Specialty Clinical Hematology. She is expert guide on sickle cell operation guidelines of Ministry of Health and Family Welfare, and she has also been the president of Delhi Society of Hematology and ex-army and referral. She has more than 200 papers and publications to her credit. And over to Dr. Jyoti ma'am for getting us through the last part of our journey of multiple myeloma, that is how to follow up a case of multiple myeloma and what role does a laboratory physician takes place in this journey of multiple myeloma treatment. Over to you, ma'am.
So we are running behind schedule. I just start with how to monitor after therapy. Dr. Deepika gave a beautiful talk on therapy. So whenever we follow up on therapy, the way back 2006 guidelines are what are used for monitoring in the beginning. So a serum protein more than 1 grams per deciliter can be monitored. A urinary M protein more than 200 milligrams per 24 hours can be monitored. Or an involved free light chain more than 100 milligrams per liter can be monitored. At this juncture, I want to also tell you all that when we talk about monitoring, it's very, very important to remember that 15% of myelomas are free light chain only myelomas, and there is no M band in them. And the sensitivity of the free light chain assay is 1,000 times that of serum protein electrophoresis. IFE is 10 times more than that, and FLC is 100 times more than that. So, FLC becomes a very, very important method of monitoring. If patients have a measurable disease in any one of these measurements, then you measure the same. But we should assess all three. Uh, 80% of the myelomas are intact immunoglobulin, and around 70% of them have a free light chain also abnormal, though 30% may not have. But these intact immunoglobulin only myelomas may also develop something called the light chain escape from plateau phenomenon, LEPP. Sorry, the spelling mistake, not LEAP, it is LEPP. Because once the patient is being treated and your M band disappears, your immunofixation becomes negative. A small refractory clone of free light chain may come up, and if there's a light chain escape from plateau phenomenon, the patients do very badly. So ideally, a patient when is being monitored should be monitored with SP, IFE, FLC, and immunoglobulins. Next slide, please. So this is before we go in for MRD. How do you monitor myelomas? It's by looking at partial response, where there is only a 50% reduction in the M protein, or more than 90% reduction in the urine M protein, or if it is free light chain, more than 50% reduction in the difference of the involved and uninvolved free light. So someone who's reporting free light chain in a follow-up case should report the difference in the involved and uninvolved free light chain and give the reduction from the previous report. Now, if all these three are unmeasurable, then if the plasma cells were more than 30% at diagnosis, a 50% reduction in plasma cells, and if someone had a plasmacytoma, a 50% reduction in the plasmacytoma is also partial response. What we want is CR and VGPR. Very good partial response where there is more than 90% reduction in the M band or absence of M band with only immunofixation being positive, which is 10 times more sensitive than the M band. And then comes in the CR or complete response where the immunofixation is also negative and the bone marrow shows less than 5% plasma cells. But we do not know whether these plasma cells are clonal or non-clonal. So came in stringent CR, which said the free light chain ratio should be normal along with CR, and the bone marrow should not have clonal plasma cells. So how are you going to look for the clonal plasma cells? By immunohistochemistry or immunofluorescence. Now, immunohistochemistry, anyone who does always knows how the background of kappa and lambda can cause problems. So that's why things evolved further. Next slide. So we just come to stringent complete response, just repeating negative IFE, disappearance of any plasmacytoma, and less than 5% plasma cells, which should not be clonal. So on immunohistochemistry, your kappa lambda ratio less than 4 is to 1 or greater than 1 is to 2. Beyond that means they are clonal. So you have to look for IHC, but better than that is immunofluorescence, and better than that is doing flow cytometry. So today we have moved into the era of flow cytometry, and the free light chain should be normal. Next slide. So this is just to recapitulate what is the free light chain monitoring. If someone is being monitored by free light chain, we can still come to stringent CR, which we already talked about. Complete CR also has normal free light, but you don't know whether the plasma cells are clonal or not. Then very good partial response is a 90% decrease. Partial response is 50% decrease, but the difference in the clonal and non-clonal, and progression if there is a 5% increase or the involved value becomes more than 100. Next slide. So evaluation of fall, how fast the free light chain falls. Day 21 fall tells you how good the response is going to be of achieving VGPR or CR. And this article led us to do a study. Next slide. Where we found that the day 21 serum free light chain after therapy was a predictor of good response. We got a cutoff of 84, and we found that it was a very, very good response for predictor of response to therapy. Next slide. So there is something called heavy light. So people would be wondering why in India we don't talk about it, because though it's been available in the market from 2017 and is FDA approved, it is yet not available for India, because the only one approved both for free light and heavy light is binding site. So at this juncture, I would like to tell you, a lot of biochemistry analyzers say that they will do free light chain assay. They are not approved for monitoring therapy. The only one approved is free light chain by binding site. So I just want to put it in the mind of a lot of people, because there are departments and places where they are doing it on the biochemical analyzers. This is not the approved method for monitoring therapy. So similarly, heavy light is yet not available for India. Next, so basically, heavy light is telling you, next slide, what is the if you remember the structure of a intact immunoglobulin, the free light and heavy light are together like this. So it is this epitope that the antibodies are, and you have IgG kappa and lambda, IgA kappa and lambda, IgM kappa and lambda, heavy light chain, and these help not only in diagnosing but also follow up of patients. Next slide. Especially in patients with IgA myelomas, where anyone who knows, you may get an IgAM band in the beta region, but you know the beta region has a hump, and monitoring response, you may miss the band. So that is why heavy light chain has become very, very important. And it is also found in this study published in 2018 that heavy light chain can help divide what comes as VGPR in normal response into CR, VGPR, and PR. And that is so different, because the survival for all three groups is very different. But this is not as yet available in India, because binding site is not being able to produce enough for US and Europe. So not available for us. Next slide. Then we move on to MRD. So we used to always say minimal residual disease, but it's moved to measurable residual disease as per the sensitivity of the test. So in myeloma, when MRD was started, and most of the articles and meta-analysis 2017 took less than 0.01% as MRD negative, because the sensitivity of the flow cytometry used to be 10 to the power of minus 4. But as per the latest guideline, with the newer drugs like upfront daratumumab and carfilzomab, as Dr. Deepika told you, first line therapy, though in India, majority of our patients may not be able to afford it, the MRD guidelines say it should be less than 0.001%. Now, MRD is a good biomarker. Next slide. Which, if you see one cell in 20 in morphology, here you're looking one in 10 to the power of 4 and one in 10 to the power of 6. So it will tell you deeper response and remission. And today we want to give the deepest response at first go so that the patient relapses late. All myelomas relapse. We want them to relapse after 10 to 15 years. Give a good therapy in the beginning. We can predict the likelihood of relapse. We can predict impending relapse. We can enable early intervention on the basis of MRD and do a robust post transplant surveillance. And it is also a surrogate marker for drug testing. Next slide. So the US FDA has even given the guidelines in 2020 January about this. Next slide. So why did we come into MRD in myeloma? We were looking at the CR, and they found with the new drugs coming in, the CR rates were improving year by year, as you can see in this table. So what they came up with, next slide, is stringent CR. Now, when they looked at stringent CR versus CR, there was just a difference of few months in the survival. You can see a little difference. CR versus stringent CR, some difference. So they went in further. This was in 2015. Next slide. And they said, let us see what happens if we look at the clonality of the 5%, less than 5% plasma cells by flow cytometry. And look at the chart B. You could separate out the ones with clonal plasma cells and non-clonal plasma cells on survival. The ones with clonal plasma cells relapsed 90% of the times. And when they went into MRD by four color will give you a sensitivity of only till less than 0.01%. Still, they found a difference. And that's when, next slide, they realized that all CRs should undergo MRD. Now, the procedure for MRD, which started, was flow cytometry, which is a low sensitivity flow. Then came up next generation flow. Now, next generation flow is higher sensitivity. Now, both these can be applicable to 100% of the patients. You don't need a diagnostic sample. Moving from this was ASO PCR, oligonucleotides specific PCR. Now, in this, in Europe for 15 years, it is approved. There is a way of following it up, and in India, no one has done it. Why? Because in this, you have to take a diagnostic sample, take out the patient's, look at the immunoglobulin rearrangements, make plasmids to do a quantitative PCR for that. So you have to develop a specific qPCR. So a lot of molecular geneticists have to work, and no one wants to do this much work. So in India, no one has developed ASO PCR for myeloma till date. Then we move on to next generation sequencing. Well, it's good, but it is not available because the approved methodology is still not available in most countries. The US FDA has approved only one, I'll just tell you about. And it is costly and you need a diagnostic sample. PET CT is required for MRD monitoring because, as we know, the distribution of myeloma cells is focal. You may do a marrow and you have MRD negative, but you may have another focal collection somewhere in the bone marrow somewhere else. So PET CT or imaging MRD is also very, very important. Next slide. So this is what I wanted to tell you, that every myeloma will have a specific immunoglobulin heavy chain rearrangement specific for that cancer. And then you have to develop primers and you have to develop quantitative PCR. Next slide. And just like we do BCR able monitoring, they do it. It's done regularly in Europe, not done in India at all. Next slide. So where do we go? We go to the new high throughput MRD technologies, next generation flow. Basically, you need two 8-color tubes, which are validated, approved by the Euroflow. It gives a sensitivity of 10 to the power of -5. Very good. It's rapid. It's got its own system, and IVD is also being developed. And you can even use automated gating. So it's a very good technology, can be done by any lab which is doing flow cytometry. Next slide. Then comes your next generation sequencing. Everyone says do NGS. Clinician says, but the NGS, you have to have a specific platform. So basically, the NGS takes lots of primers. So ASO PCR, we had to develop patient specific primers. Here you have so many primers, you pick up the patient's mutation. So it has the speed, but the cost is the issue. Even in USA, only one company, Clonosec, by adaptive biotechnology based NGS is approved. Nothing else is approved for B cell malignancies. Next slide. So just coming to the principle, Basically, the sample is the DNA is barcoded, put into a super multiplex PCR. You get a lot of material. You look use a bioinformatics pipeline. You error correct, you clean, you compress, and then you get out the data, and you know which mutation this patient has. And in the subsequent NGS, you look at the depletion of these mutations. So just to show you, next slide, what is the principle of next generation sequencing? When you have a sample for a bone marrow sample from a patient with myeloma, it will have non-B leukocytes, myelocytes, metamyelocytes, all other cells. It will have normal B cells, and it will have leukemic B cells. So you quantitate the DNA, and from the quantification of the DNA, you get the total number of leukocytes by going by DNA per cell. Then you extract the DNA, and while you're amplifying the DNA, you also add known quantity of reference immunoglobulin heavy chain. Now, this known quantity, like in flow cytometry, we had the beads. This is going to give you the count. So once you sequence, you get the number of B cell reads, you get the number of leukemic B cell or myeloma cell reads, and you get the number of reference reads. And from this, you calculate the frequency of the leukemia clone amongst the B cell, and also the number of leukemia molecule per leukocyte. And that is how you can report the minimal residual disease on NGS. Next slide. So NGS not available in most countries, but it has a higher sensitivity. It can be done in almost 90% of the patients, whereas flow can be done on more than 95% of the patients. The LOD and LOQ of NGS is slightly low. So LOD, LOQ, anyone working on lab quality will understand limit of detection and limit of quantification. Now, when we do for NGF or flow, we can detect till 20 abnormal events in 10 to the power of 7, but to quantify them they should be at least 50, and that's what has been found. And any lab, like we've been doing myeloma MRD since 2017, has to develop and validates its LOD and LOQ. Next slide. So when you're looking at the sensitivity of the assay, whenever you run any normal sample, you get some background. So that background is the limit of blank. So we do 10 samples, we come to the limit of mean of blank, and plus 1 SD is the limit of blank. Plus 3 SD to the mean of blank is LOD, and that is the analytical sensitivity. Next slide. So just to give you an example, and also to tell you that imprecision till 20 to 35% CV is allowed. So if you're going for accreditation NABL of a lab, accepted in imprecision in LOD LOQ is 20 to 35 CV. Now, just to give you an example, if you've just acquired 1 lakh cells, then your 20 events LOD, your sensitivity will be just 0.02. It's useless. So you have to get a sensitivity of 0.01. The old MRD negativity, at least 5 lakh cells are required. And to get today's sensitivity, you have to acquire 5 million cells to give a proper LOD and LOQ in the myeloma report. Next slide. So why did all this come in? When everyone said cytogenetics, we had a talk on that. High risk cytogenetics means bad. But then they found that when there was presence or absence of day 100 post ASCT, post allogenic autologous stem cell, day 100 MRD on the bone marrow, that overcome the effect of the bad or good cytogenetics. So became an independent marker for prognosis and monitoring. So they said it should be done in all, and the ones who are positive will behave poorly. Now, Dr. Deepika told you about some transplant ineligible patients. So the GEM 2005 looked at these elderly patients, and they found the difference between 4 cycles and 6 cycles, and they found anyone who became MRD had a better progression-free survival. Next slide. Then the Medical Research Council of Myeloma came up with the data. This was also with the low sensitivity, just 5 lakh events in a tube, that at the time of diagnosis, end of induction, and day 100, MF flow cytometry has a major role. At the time of diagnosis, you look at the ratio of the clonal to non-clonal plasma cells. So if they are more than 90% at diagnosis are clonal and 10% are non-clonal, it is a myeloma uh, phenotype. And if it's vice versa, majority are non-clonal, it is a MGUS phenotype, and they also behave prognostically different. But here, day 100 and end of induction, MRD had a very, very important effect. It told you how the patient was going to behave. Next slide. So based on all these data, Dr. Munshi, who till last year was the president of the International Myeloma Federation, did a meta-analysis of these studies, and he found that the MRD was very good, and only till 10 to the power of minus 4 using multiparametric flow cytometry worked very well. And then the question came up, is higher sensitivity better predictive? So they looked at, next slide, the data of the ASO PCR. Next slide, please. And they found, yes, it's much, much better if you have deeper remission. So they said, okay, let's go in for deeper remission. And that's why the NGF, next generation flow, and next generation uh, sequencing came into play. Next slide. So the International Myeloma Working Group talked about MRD in 2016, updated in 2022. They talked about, with the new drug, sustained MRD negativity. So MRD negativity in the marrow by next generation flow or NGS or both, persistent for 1 year, was sustained MRD negative. It could be longer. Then there was flow MRD negative, what we have talked about. But for this, they said the sensitivity should be at least 1 into 10 to the power of minus 1 into 10 to the power of 5. That means giving less than 0.001%. Sequencing MRD negative, two identical sequencing reads should be negative and only on the clonosec platform. Imaging MRD negative is on the basis of PET CT, and that has to be also done. And imaging plus means bone marrow plus imaging negative. Next slide. So in 2020, because deeper sensitivity was seen with the NGF, Dr. Munshi came up with his new meta-analysis, and he found that the deeper the MRD sensitivity, better was the lower was the hazard ratio, and better was the overall survival as well as progression-free survival. So today the aim is to achieve MRD less than 0.001%. Next slide. So whatever all this data is telling you, at any time, post-induction, maintenance, after salvage, MRD predicts what is going to happen to the patient. And it's very good for monitoring. Next slide. So from PR, VGPR, CR, and CR, which is MRD negative. But in India, most of the centers, people don't even look for MRD negative CR. This has shifted to MRD minus 4, MRD minus 5, MRD minus 6. So things have changed with the new drugs coming in. Next slide. So the next generation flow, if someone wants to start, they are the Euroflow guidelines, which say at least 2 8-color tubes have to be there, and each tube 5 million, so you should have total 10 million events to give a good report. Now, the markers were already talked about, so I'm not going into the details, but you look at clonality also by kappa lambda, and you look at for the aberrancies, and you gate by 138 and 38. Then the US validated a single 10-color tube, and that was used in Mayo Clinic. So one can go in for any of these two. Next slide. So in 2016, we also started looking. So this is a post-transplant. Next slide. So in 2016, so here we get the CD38 and 138 positive cells. And in that, we separate out the normal and the abnormal plasma cells. So the normal plasma cells are CD19 positive, 56 negative, and the abnormal ones are 19 negative and 56 positive. And then we look at the clonality. Next slide. And finally, we come down to, if you can see, total number of non-debris cells are 2,047,000,000, and the cells, plasma cells abnormal are 215. So the MRD is 0.008%. So you now don't say less than 0.01%, you write 0.008%, giving the LOD and LOQ. So this was in the 2 8-color tube. Next slide. As things changed, we also moved to a 12-color tube since 2018, and been done a large number of cases on that. And here we added another tube, CD319. Why did we add this tube? Because daratumumab, as Dr. Deepika told you, is an anti-CD38 antibody. So CD38 cannot be used for gating the plasma cells now. So 319 was added. And then next slide. This is just to show the flow. Now, here's a very interesting thing. We have gated, if you can see in the second row, the abnormal plasma cells as red and the normal CD19 positive plasma cells as yellow. Now, if you look at the aberrancies taking CD28, 27, 117 and clonality, the red ones are all clonal. But, and you can see the blue is kappa lambda of the normal B cells, which are polyclonal. But if you look at the last row, these yellow cells, they are showing the same aberrancy as the abnormal plasma cells. And they are also kappa clonal. So when you have something looking like normal plasma cell, they should also be checked thoroughly, and the MRD will be a total of both when you give the minimal residual disease. Next slide. And this is how we give our report in our department. And you see, the report should tell what color, 12 color, how many laser, what is the gating strategy. That should be part of every report as per the guidelines. And then you move on to giving the LOD and LOQ. So that gives you exactly what is happening. Next slide. What is very, very important, the peripheral blood count should come to you with the bone marrow. The marrow should be a first pull, it should not be diluted. Please tell your clinicians. The problem happens where people are sending the sample to a standalone lab, which asks for flow samples of normal ALL MRD or normal flow cytometry for leukemia and heparin. Heparin should never be used for myeloma MRD. Heparin is CD38. It will give all wrong reports. So it has to be EDTA sample. If any drugs have been given, daratumumab has been given, it should be told, because then the gating will be done with CD319. Similarly, here I come to daratumumab also in patients with IFE. When you're looking at immunofixation, you will get an IgG kappa band. Daratumumab is a IgG kappa monoclonal antibody, and you'll say, oh, this patient has developed some new clone M band. So when a patient is on daratumumab, if you have to do the monitoring with SP and IFE, please do it just before the next dose of daratumumab so that the effect is minimum. And even flow cytometry, if you have to do, ideally do it, if you've given a daratumumab maintenance, as Dr. Deepika told you about, then do it just before the next dose of daratumumab to get minimal effect.
Yeah, I'm in a webinar. I'll call you back.
And what is most important is the clinician and the lab should insist that please inform us you're planning to do a myeloma MRT. They should never send it on a Saturday evening. The plasma cells are very, very friable. If they're kept for more than 24 hours, you'll have so much kachara in your flow cytometry that you'll be struggling. So that is very, very important. Next slide. The clinician should also understand, we have to educate them to look at the TLC, to look at the adequacy of the sample in the report, because sometimes standalone labs may give a report without adequacy. So the mast cells, the nucleated red cells, the normal plasma cells, the PDC, the report should clearly have more than 8 color, 2 tubes or 1 more than 10. The daratumumab based CD319 or multi-epitope 38 or CD229, etc. should be there if you're giving daratumumab. Number of events acquired should be there, which will tell the sensitivity of the test, and MRD should be not reported as less than 0.01 negative. It should be reported as the value, because today 0.001% becomes negative. And the LOD LOQ should be clearly mentioned, because it will change with the number of samples acquired, number of cells acquired. Next slide. So the time points for MRD are after induction, after stem cell transplant, after consolidation, after maintenance. What will it do at after induction? As Dr. Deepika said, some patients don't want to immediately go for a stem cell. If the MRD is negative, you can collect their stem cells, cryopreserve it, and let them continue on maintenance. Post stem cell transplant, MRD is positive, they have to undergo consolidation. You can tell the patient about the use of consolidation. Post consolidation, decision on taking maintenance. Now there are trials trying to say we can cut down maintenance as MRD is negative. A lot of trials are on. But as of now, Maintenance is generally lenalidomide, and we all know about the issue of secondary malignancies due to cancers coming due to lenalidomide. So someone who's MRD negative persistent may take an informed decision, taking the risk benefit into doubt, to stop temporarily the lenalidomide. So all these things have come into play in the monitoring post therapy. Next slide. Now, someone has asked the question, what does MRD mean? MRD used to mean minimal residual disease, but today it is measurable residual disease, much below what you see on morphology, 1 in 20 cells. You are looking at 1 in 10 to the power of minus 5, 1 into 10 to the power of 5 or 6 cells. So the sensitivity is 1 into 10 to the power of minus 5. Now, a lot of trials are looking at MRD for next generation techniques. Next slide. And giving a lot of data. They are this big trial in 2024. At every stage, there are trials going on to see how MRD works. Next slide. And that will be the treatment strategies for tomorrow. Now, we also try to look in our department, and something simple post transplant MRD after the autologous stem cell transplant helped change therapy in 10 of our patients. Next slide. This was presented 2 years back at the national conference. And in these 10 patients, based on the MRD, the therapy could be changed and the patient could be sent into remission. Next slide. So, to conclude, it's been a long session for all of you. Should MRD negative by next generation flow, which we say less than 0.001%, be the end point in India? Well, it's difficult because today in many centers, they are not even looking at CR with clonal plasma cells or without clonal plasma cells by low sensitivity flow. The aim world over is to eradicate MRD, to maintain undetectable MRD less than 0.001%, look at therapy, look at treatment decisions. But in India, NGF is not available in many places. So wherever there is a flow cytometer, everyone should start with a multi-parametric flow cytometry only. Give it with a sensitivity of 0.01, 10 to the power of minus 4. Look at MRD at CR, because that also has got a very, very prognostic thing, as you saw in the meta-analysis of 2017. If we can reach that stage in developing countries in India, in every center, that is also good enough. And do a day 100 post autologous stem cell transplant and take decisions accordingly. Because slowly from those in those centers, we also started with 8 color 2 tubes, and now we've gone to 12 color. You have to start working, and we are doing NGF. But before we started the 8 color 2 tube, we also started with the way back in 2013-14 with a 6 color tube. So you have to start working on this. And every pathologist who's doing flow cytometry, every pathologist or hematopathologist or biochemist who's doing free light chain, SP, IFE should understand what is the importance and how the monitoring should be done, so that we can give quality monitoring to our patients with myeloma. Thank you.
Thank you, Jyoti ma'am, for an excellent talk. And we all agree that we had so much to learn from today's talks, which gives us the nutshell that this is an aggressive disease, and we together, the clinicians, the laboratory physicians, we have to fight aggressively and monitor aggressively to treat and maintain our patients in remission.